My disclosures, I have a couple of books royalties, and my wife is a pharmaceutical executive. I guarantee you that she could care less what I'm going to tell you about pleural disease. I'm the kind of radiologist that believes that every abnormal finding we recognize, we should also try to ascribe an etiology and a clinical significance to. And with pleural disease, that's incredibly difficult. As you know, it's a common, usually very nonspecific finding, and in many cases we have no direct and clinical information. And so it makes it very difficult to know what to do with this finding. And hopefully over the course of the next half hour, we're going to talk about the causes of pleural disease, and the imaging features of pleural effusion, thickening, and masses, and to identify those features that add specificity to the diagnosis. In addition, I'd like you to be aware of certain clinical clues to pleural diagnosis that are basically hidden on the chest radiograph or the chest CT that might add some specificity. So when I was a medical student and learning about pleural effusions, I'm sure I got a list something like this. You know, 1,000 things long, under big categories, and how the hell can you remember all that stuff? And honestly, this is a great list for an internist, but it's a terrible list for a radiologist. And I personally think that we should be thinking about pleural effusions this way, which are those things that typically cause unilateral effusions, and those things that typically cause bilateral effusions, and then those things that can cause either unilateral or bilateral abnormalities. And then we should also think about them in terms of commonality. So there's certain things that occur every day. Cirrhosis and parapneumonic effusions are typically unilateral. CHF and malnutrition-related effusions are commonly bilateral. And then postoperative effusions, metastasis, trauma, things like ascites and pancreatitis and peritonitis and other diseases below the diaphragm are often bilateral or unilateral, and then radiation therapy. So everyday things. And then slightly less common things like pulmonary embolism, empyema and mesothelioma, lymphoma, collagen vascular diseases, viral pleuritis and nephrotic syndrome, and then even more uncommon things like tuberculosis, Dressler syndrome, asbestos effusions, chylous effusions, medications and hypothyroidism. So still, maybe a little bit better than the last list, but still really long and hard to know how to decide which thing to pick. So are there any other things that we can figure out to add specificity to pleural disease? Well, loculations can actually do that. Loculations are collections of pleural fluid that are not gravitationally dependent. They characteristically have convex borders like these on the CT scan and like this on the plain film. And in order to get loculations, you have to have pleural adhesions. Pleural adhesions only form in the setting of inflammation or malignancy, and therefore the presence of loculations implies that the effusion is exudative in character. So if we look at our list, again, and we now make it causes of exudative effusions, we can lop off cirrhosis and ascites, CHF and malnutrition, nephrotic syndrome and hypothyroidism, and we get a list like this. Still not very good, but a little bit better, right? So are there other features that can help us to try to figure out what to do? Well, this is a 65-year-old man, status post-esophageal gastrectomy, 10 days previously, and I think you can all see that there are bilateral pleural effusions, a small low attenuation effusion on the left, but a larger high attenuation effusion on the right. We all know that that's a manifestation of acute blood. And so this person has a hemothorax on the right as a complication of their surgery. Typically, we have recognized this on unenhanced CT, as in this case, but if you give contrast, you can still usually recognize that the pleural effusion is a hemothorax because the attenuation is too high. Pleural thickening will also add specificity. This is soft tissue attenuation between the ribs and the lung. And that soft tissue is either malignancy or inflammation or fibrosis. And so every time whenever you think pleural thickening, you should be thinking malignancy, inflammation, and fibrosis. And as you can recognize, all of those things are a manifestation of either current or previous exudative effusions. So once again, this is a manifestation of exudative pleural disease. It turns out that the character of the pleural thickening can also add specificity. There are certain features that are highly associated with malignancy, and they are mediastinal involvement, fissural involvement, and nodularity. And so we have two examples here of pleural thickening. Here on the left, fairly uniform pleural thickening, and then these nodular areas. This nodularity is highly associated with malignancy, and this person had mesothelioma. Here we have a person with a loculated pleural effusion, and there's pleural thickening, but notice that it involves the mediastinal pleura. This is a feature that's highly associated with malignant pleural effusions. The vast majority of cases that have this feature will be malignant in nature, and this person had breast cancer. We can also see these findings on plain films. So here's a person with diffuse lobular pleural thickening along the right lateral and medial thorax. There's actually thickening of the major fissure also. This is a finding which should suggest malignancy on a chest X-ray. Let me tell you that most metastatic malignant pleural processes will cause pleural effusion, and you won't be able to see the thickening on a chest X-ray. What you will see is a pleural effusion, and you'll only recognize the thickening on CT. The one tumor that most characteristically gives you pleural thickening on a chest X-ray is mesothelioma, and that's in fact what this person had. So if you see nodular pleural thickening on a chest X-ray, it will most often be mesothelioma, one of the less common causes of malignant pleural thickening. So if we look at all causes of diffuse pleural thickening, the only one that is everyday common thing that we see day in, day out are metastasis. And this can be smooth pleural thickening or nodular pleural thickening, any kind of pleural thickening every day. Most often that's going to be malignant. Less common causes include mesothelioma and lymphoma, and inflammatory and fibrotic causes, empyema and prior hemothorax. Rare causes include tuberculosis, collagen vascular diseases like rheumatoid arthritis, lupus, and mixed connective tissue disease, Dressler's syndrome, and asbestos effusion. And at least theoretically, probably all other exudative effusions can potentially do this. In practice, it's relatively uncommon for them to. So let's look at an example. This is a 41-year-old woman with rheumatoid arthritis and dyspnea, and I think you all can see the loculated pleural effusions bilaterally. When we put in a chest tube in this person, we notice that the lung doesn't collapse. And if you look, we can infer the presence of visceral pleural thickening trapping the lung and preventing it from expanding. And if you look carefully, I think you can faintly see a sort of thick line that runs here in the background of the whiter area, and that represents the pleural thickening. It's obviously very difficult to see on the chest X-ray, but if we get a CT scan here, we have, again, in this case, fluid and air in the pleural space, and you can see this lobulated pleural thickening along the, smooth pleural thickening along the visceral surface and also on the parietal surface of both lungs, and this is pleural thickening due to rheumatoid arthritis. This 45-year-old Asian man has a history of cirrhosis and complained of dyspnea and fever. He has an obvious pleural effusion on the right. It appears to be at least partially loculated, and it has diffuse, smooth pleural thickening. But notice that there's this subpleural band underneath the enhancing pleura that's lower attenuation. That's a feature called the split pleura sign, and it represents enhancement of the pleura and subpleural edema. And it is highly suggestive of an empyema. So if you see that finding, it's often a manifestation of empyema. Other findings associated, other findings that can be seen that indicate or suggest the diagnosis of empyema is air in the pleural space. Here we have an example of that. We have a person with a large loculated right pleural effusion. He presented with malaise, anorexia, and weight loss and fever. Sorry, I missed that. And if we look at a CT scan, in addition to the pleural thickening and the loculated effusion, we see little droplets of air in the pleural space. Air in the pleural space is most often iatrogenic and related to recent instrumentation, but if there's no previous recent instrumentation, air in the pleural space nearly always indicates the presence of pleural space infection, i.e. empyema. Focal pleural thickening. So the pleural thickening we've seen so far has been diffuse. over large surfaces of the pleura. Occasionally we can see focal pleural thickening like this. It's seen to lesser degree on the left lateral chest wall, and we can also see areas on FOSS as these edges with whiter and darker areas. And as you all know, this is characteristic of non-calcified asbestos-related pleural plaques. Pleural plaques characteristically have this plateau shape. They have a flat superior surface and then sloped sides. And if you see that, this is essentially diagnostic of asbestos-related pleural disease. And pleural plaques are really the only cause of focal pleural thickening that I know of. We can also see asbestos plaques on CT, and again, we see the similar plateau shape to these multiple pleural plaques. So once again, focal pleural thickening, plateau shape, multifocal and bilateral, can involve any of the pleural surfaces, and that is very characteristic of asbestos-related pleural plaques. Increased pleural attenuation will, in most cases, indicate pleural calcification. Here on the chest X-ray, we see these serpentine focal areas of pleural calcification, which are seen better on the CT scan. And hopefully you all recognize again the characteristic plateau shape of asbestos-related pleural plaques, which are now calcified. Notice that the calcification characteristically occurs at the base of the plaque. I don't know why we need to know that, but it does, and so anyway. So these, once again, are calcified asbestos-related pleural plaques. Diffuse pleural calcification, on the other hand, is somewhat different. Here we see a long segment of pleural calcification in the right hemithorax, which has caused restriction of the right lung, and we see a similar finding on CT. Causes of diffuse pleural thickening are most often due to prior empyema, prior hemothorax, or prior tuberculous effusion. Of these, the one that's most important to recognize is tuberculosis because of the potential risks of reactivation, or well, whatever, of recurrence of the disease. Less common causes of diffuse pleural calcification include prior benign asbestos effusion and probably also other exudative effusions, although, again, very, very rare outside of the 3 or 4 that we've noted here. Here we have a 60-year-old man who had radiation therapy for lung cancer, and we see the zone of radiation fibrosis in the left lung, and we see this area of increased attenuation in the pleural space. But notice how it appears different from the previous exams. This high attenuation is amorphous, sort of a stippled appearance, and it's nonlinear. This is diagnostic of one thing. Anyone want to tell me what it is? Talc. So this is characteristic of a previous talc pleurodesis, and if you see this finding, it's diagnostic of that cause. Pleural masses, as you all know, characteristically cause the extrapleural sign, where we have this dome-shaped mass with a sharp medial border and an indistinct lateral border. These are actually relatively rare findings, so there's no common causes, but less common causes are most often solitary fibrous tumor and pleural lipoma. In this case, we did a CT scan, and you can see the fat in the pleural space, and this represents a lipoma. Rare causes of pleural masses include metastasis, mesothelioma, maybe. I'll show you an example of mesothelioma. And as we saw in the tests, what do they call it, the panel that they did on Saturday or Sunday, talcomas can also occasionally cause that. Collections of talc will sometimes appear as a mass. Here's an example of a solitary fibrous tumor of the pleura. They can be small to giant, although most often we recognize when they're very, very large, as in this case. They typically have smooth margins and are often at the lung base. One thing that old-time radiologists know is that they are characteristically pedunculated, and so in fact they can flop around in the pleural space. And so in the olden days, people like my dad used to turn people on their side and watch the thing move in the pleural space, and then you would say, aha, this is a solitary fibrous tumor of the pleura. On CT scan, they characteristically look like well, listen, they can occasionally be homogeneous in appearance, but when they're large like this, they're often very heterogeneous. They have these swirling patterns of enhancement that are in some ways reminiscent of fibroids of the uterus, and they're a similar kind of tumor. Remember that there are two metabolic syndromes associated with this, hypoglycemia and hypertrophic osteoarthropathy, and this patient actually had hypertrophic osteoarthropathy. Say that fast 3 times. And you can all see the diffuse periostitis of the forearm here. Actually, I guess it's the leg. Take that back. So most people with metastasis to the pleura will cause pleural effusions. To get solitary masses in the pleural space is uncommon, solitary or multiple. But they do occasionally occur with response to metastasis. Here's an example of a person that had ovarian cancer and this solitary mass that we ultimately diagnosed as metastatic tumor. As I said, it's in most cases pleural metastasis. You're going to see a pleural effusion on chest x-rays, and on CTs you'll see the mass embedded in the pleural fluid. The one anyone want to tell me what the one tumor that characteristically gives you pleural masses without effusions? We saw it this morning. Thymoma. And so for reasons which are not clear, to me at least, metastatic thymoma characteristically gives you pleural masses without effusion. And so if you see a pleural mass that you think might be a metastasis, make sure you look in the anterior mediastinum. I've seen at least 2 cases where people recognized the pleural disease and missed the mediastinal mass and missed the diagnosis as a result of it. Here's my example of mesothelioma appearing as a solitary mass. There's this giant mass in the apex. It honestly looks more like a lung cancer to me. But on CT, we see this sort of tumor wrapping around the apex of the lung. And this is an epithelial mesothelioma. In most cases, mesothelioma is going to appear as a pleural effusion or diffuse pleural thickening like that first case we saw earlier. But occasionally they can appear as a big mass like this. As you can see, they're much more ugly looking masses than the benign tumors, the solitary fibrous tumors and the lipomas. As you all know, clinical history often provides the critical information for diagnosis. And if we're lucky, our clinicians will give that to us. But very frequently they don't. And when that happens, you have to be smart. And you have to look for unstated clinical clues that are present on the imaging exam or acquired some other way. So look for surgical hardware. Is the patient an inpatient or an outpatient? Rate of change on serial exams, and other imaging findings that might add specificity to the pleural effusion that you recognize or the pleural process that you recognize. Also remember to use demographics. What's most common in your practice? The things that you find are most often going to be the things that are common. But let's look at some examples here. So, good. So here's a patient, and we can see this uniform opacity at the right lung base, which is the characteristic appearance of pleural effusion on a semi-erect film. So we all recognize a pleural effusion on the right, but there's lots of information here. The person has multiple sternal wires. He's got a mediastinal drain. He's got a left chest tube. And so we should all recognize that this guy has had recent cardiac surgery. In fact, he was post-op AVR, and so this pleural effusion is a post-operative complication, right? It's just a standard effusion that we see after surgery, and you can recognize that without any clinical history. Here's another example. This person has small bilateral pleural effusions. Anyone want to make the diagnosis? So someone over here said cirrhosis, and actually the liver is a little bit small in size. One of the things what I would say is we have ascites here. And we have, in addition to the pleural effusions, and if you look at the fat in the background, the fat is all indurated, right? There's edema in the fat surrounding the body. So this person has effusions, ascites, and anasarca. That triplet usually indicates poor nutrition and hypoalbuminemia, which is what this person had. His albumin level was 1.9, and we can recognize that from the imaging exam without knowing anything about the patient. Here we have another patient, obvious pleural effusion on the lateral. We see the meniscus sign, probably a little bit of atelectasis medially. completely nonspecific, right? But if we look at his old exams, this is what we find out. Well, first, I haven't shown you his pre-op film, but we figured out that this film was actually taken post-op day 44. This is post-op day 6. He has a little atelectasis, but really no pleural effusion. Post-op day 30, he's got a small pleural effusion, and it's bigger on post-op day 44. Anyone want to make a diagnosis? Thank you very much. Someone said Dressler syndrome, and this is an example of Dressler syndrome. That's an inflammatory effusion, idiopathic inflammatory effusion that occurs in the few weeks to a month after pericardial incision or after myocardial infarction. It characteristically presents clinically with fevers and chest pain and often a rub, and is treated with endomethacin. And so this is an example of Dressler syndrome that we can recognize based just on imaging. Here we have a 57-year-old man, HIV positive, with fever and cough, and in addition to the pleural effusion, we see this extensive consolidation in the right lower lobe. It's a no-brainer that this pleural effusion is secondary to a pneumonia in the right lower lobe. This turned out to be a Pseudomonas pneumonia. And so, again, imaging features help us to figure out what the pleural effusion is due to. Here we have a 49-year-old woman with dyspnea. She has this large pleural effusion. It appears like it's probably loculated, but the key finding is actually right here. We see this soft tissue attenuation mass draped over the vertebral body. That's a characteristic appearance of lymphoma in the posterior mediastinum, right? And so that finding helps us to suggest two potential diagnoses for this pleural effusion. One is a malignant effusion due to lymphomatous involvement of the pleura, and the second is a chylous effusion related to obstruction of the thoracic duct by the lymphoma. And hopefully many of you also recognize this high attenuation material in lymph nodes in the posterior mediastinum and a little bit of it leaking into the pleural space, and so this person had a lymphangiogram and actually proved that this was a chylous effusion. But we could have at least predicted that based on the presence of the mediastinal mass. So chylous effusions are most often, at least in my practice, due to trauma, primarily esophageal surgery. This is not surprising. The thoracic duct and the esophagus are right next to each other, and so it's not hard for the surgeon to accidentally disrupt the duct. Occasionally, other thoracic surgery or penetrating wounds like bullet injuries will also result in chylous effusions. Masses in the mediastinum are a known cause, but incredibly rare. I've only ever seen a handful of cases in my practice, and then occasionally other disorders of the lymphatic systems like LAM and things. So this is my final case, and we have a person with a loculated effusion, and he has mediastinal pleural thickening. And so that's a finding which is associated with malignancy. But actually, if we look here, he's got an enhancing pleura with subpleural edema. It looks like he has the split pleural sign. That's usually associated with empyema. So we're getting a little bit confused here. And then when I finally talked to the clinicians, they said, oh, yeah, this is a guy who lived in Nigeria, and he's now presenting with fever and weight loss. Anyone want to tell me the diagnosis is? Yeah, this is tuberculosis. Tuberculosis is the only non-malignant cause that I have seen that causes mediastinal pleural thickening. So when you see mediastinal pleural thickening, it's nearly always malignant, but I've now seen 2 cases of tuberculosis effusions that did this, and so that's the one other thing that I think about in that clinical setting, or given that imaging finding. So what have we talked about today? We've talked about causes of pleural effusions, and I think that we should start off with things that are commonly unilateral, things that are commonly bilateral, and then things that are everyday, things that are less common, and things that are uncommon. And order our differential diagnosis based on those characteristics. There are findings that increase the specificity of pleural disease. If you have loculations or pleural thickening, those are associated with exudative effusions. If your pleural thickening involves the mediastinal pleura, the fissural pleura, or appears nodular, that's nearly always malignant in nature. Most pleural masses are smooth and are benign tumors, typically solitary fibrous tumor of the pleura and lipoma. Less common causes are malignant causes, but very, very rare. Diffuse pleural calcification is in most cases due to prior empyema, prior hemothorax, or prior tuberculosis. And asbestos plaques and talc have unique appearances which are diagnostic based on imaging appearance. Clinical history often provides the key information to make a diagnosis, so look for unstated clinical clues like surgical hardware, is the patient an inpatient or outpatient, rate of change on exams, and other imaging findings that might help you to determine the etiology. And then lastly, use demographics as necessary. I was actually told I'm supposed to provide a question.